Dr. Kini, you're live.
Yeah.
Let's present the case and
Case
move
number,
forward.
Yeah, we have case number 5. 59-year-old male, same, presented with angina class 3 and dyspnea, a history of hypertension, hyperlipidemia, diabetes, and important was CKD stage 3. Creatinine runs between 2.7 to 3.0 and had a SPECT MPI outside which had shown a moderate reversible ischemia infralateral wall, and because of the low EF, he was referred for cardiac cath. You can see he was on good medical therapy already. So cath had actually shown that he did have 3 vessel disease with low EF. So you see that about 70-80% disease in the mid LAD and totally occluded circumflex. Then had a complex, angulated with the ectatic segment of the mid RCA. So the plan was that we do a IFR guided PCI of the LAD. So we have the IFR which we did. Can you show the IFR there was 0.72. Just did the LAD PCI. That's the final picture of the LAD post dilated. And this is where you have the circ totally occluded, but you can see filling from the left side itself. And this is where we are with that right coronary artery. Minimal calcium, I would say, just mild calcium, but more important is the mid part of the vessel where you see the lesion is angulated, ectatic. So we just wanted to go over that in the setting of Impella, same thing which we went through even in the first case, 3 vessel disease, low EF, CKD, that in this kind of a case that how could we, he did have a heart team discussion, and what was the reason they, because, yeah. Morbidity due to renal insufficiency and low EF, that they felt that the risk of him needing dialysis after surgery would be higher.
So another very complex case, low ejection fraction, multi-vessel disease, chronic kidney disease, another Impella-assisted, multi-vessel PCI. We've got a new panel here for you, and I think there'll be a lot of nice discussion. I'm glad we're going to have a little bit of time just to have some discussion. We see that she's already proceeded with an FFR-guided PCI of IFR-guided, physiology-guided PCI using IFR in the LAD. We've got, you heard about the Cindy, what do you think about this, the use of Impella? Let's start with that. I think before the panelists were a little bit shy about using Impella. What do you think? Would you proceed without?
Well, I think that it's 3 vessel disease. It appears the syntax score is, moderately high. I certainly wouldn't want to spend a lot of contrast on this case. I'd be inclined to do a lot of IVUS guiding in terms of determining exactly where the stent borders should be. I would definitely avoid OCT to avoid giving additional contrast. Yeah. But I personally would probably put an Impella in just because you have a lot of issues. You have a low EF, you have CKD stage 3B, it sounds like, yeah, and very complex right coronary stenosis.
So I think everyone on the panel agrees, right? No, Jazz is saying no.
And the data Impella
lesion has a CTO of the circumflex and a mid-LAD lesion, and patient has EF is low. Listen, you take a renal patient's bleeding risk is high. So you have to weigh risk and benefit here. And also you're taking a big thing up the aorta, which has diffuse atherosclerosis also. You're on the risk of embolization too. So you have to weigh risk and benefit. And I think this case, you have 3 vessel disease, focal, and LV function is low. I would not use Impella in this setting.
You didn't, Ron, you would use Impella, yes or no?
I can use
You're more friendly now to Impella.
I'm very friendly to Impella.
Oh, good, good.
As a matter of fact, the guidelines has been changed now. You don't have to have a low EF.
Yeah, exactly.
So I think the issue here is probably the Impella is already there, so the iliacs are good. If the iliacs are good, I don't see any issue.
Why not?
Whether I'm going to keep the Impella after the case, probably not.
Okay.
But this case should be, also you can think about staging this case because of the renal function. You may not need to do all the vessels at the same.
But we heard that once you put the Impella, you're going through all this trouble. You
But
might
the
as well do
renal is
everything.
the issue. How much
right?
contrast you got?
Yeah.
And I think she worked very hard not to use a lot of dye. How much dye did you use, Anu, for the
We
first?
had to do iliac pictures. Other than that, the total so far is about 40 cc dye only. His EDP was 25. And, Impella has been with us for almost close to more than an hour here, so which might improve his kidney function also, knowing the recent study showing that Impella does improve the renal perfusion.
Certainly,
and therefore the
yeah, so
creatinine.
that's-
And EF, I just want to show that EF is 30%.
Yeah. So Jeff, what do you think? Let's not. I don't want to talk too much more about
So
the
question,
Impella,
is
but
anybody
what
using
about
the Osprey medical device, the contrast saver? Are you guys familiar with that?
Yeah.
Where when you inject this, has anybody had experience with that? And
We
would you
actually
use it?
performed. We probably randomized the most number of patients here at Mount Sinai. You do reduce the dye, but now there's a divert that actually does a lot more. It wasn't enough to reduce contrast nephropathy, but we hope to take a look at that in the future. Dr. Sharma and Dr. Kini, what's your strategy for the right coronary? Are you?
I think right coronary would be just balloon and stent, but I think the discussion here would be having seen that angulated and I would say ectatic, not aneurysm, ectatic, that what is the selection of wires in this kind of a situation, and same thing, creatinine is high, that you will just use the roadmap and wire this vessel. So I think selection of wire would be the same if out there. Do we go with the usual workhorse wire, which could be here today we are going to use the Xion Blue from Abbott, which is the workhorse today, or do we go with the Fielder wire, or you think we will need a specialty wires that once we try this, we have to be ready that you may need a
Fielder would
specialty
be
wire
fine.
with you to wire this vessel, which could be the Gaia wire.
I think keep it simple with your usual wires, right? I mean, I
Okay.
think that knowing your skills, I think you'll get through with a normal workhorse wire. I don't really have, but my bone here with you is why aren't you doing this radially?
Yes, good question. Why
Less bleeding.
radial?
She already occupied, yeah.
Yeah, and
there's no answer to
there is a trial, the music trial, which looked at patients with CKD, and if it's IVUS guided, I think they reduced the contrast utilization to about 35% for cath possible, including the PCI. So it is doable. It just takes.
Published actually no contrast at all.
Zero contrast.
Yeah, with the,
That's-
Zero is
yeah.
maybe excessive, but you can, if you use IVUS here, you can
Right.
really minimize by a lot.
Exactly, but it's just a lot of time. It's
You
going
see
in and
that
out, in and
Dr.
out,
Kinney's
so-
already fully wired this. You see, I had full confidence that you would
It's a
get there
fly-through wire.
with
Right.
your normal wire.
Yeah,
Xion Blue is a great wire.
There's two things. One, I think Siemens and Philips has a thing called dynamic coronary roadmap. So when I do these complicated cases, you take a picture, it gives you a nice roadmap. You can wire without contrast. And then I agree that with IVUS, you can pretty much do these cases without injections.
contrast.
Yes.
John Fox, any comments?
Well, I loved your thought about keeping it simple. So I think that looking at the anatomy in these lesions, I would stage it and not use the Impella. And I think you can also find landmarks of calcium where you can really place stents fairly accurately without even having to use a lot of test injections.
Yeah, and
So would anybody
always
go
know
after-
that-
So you
Go
see
ahead.
that so far we've not given any dye at all. We wired without dye.
Yeah, I was just
Right,
going to say
that's-
that.
Good.
I was
If you
just
do
going to
IVUS,
say
you don't
that. I
need to
mean,
do any
I've been
dye,
in cases with Anu, and both Dr. Kinney and Dr. Sharma, they are really, really careful in these CKD patients. If we give dye, we get yelled at. So nobody gives you a dye. And it's a real, you see they're wiring without, but I mean, obviously, it's really important, the contrast volume, incredibly important. And I believe having had to go an hour of Impella, you're improving renal perfusion, actually. And I do think that this is kind of interesting for these types of patients, just kind of really hydrating them and giving them good perfusion going forward. John?
538
I
CR.
tell you, you hate to get into any kind of complications in these patients, so
Yeah.
I really, the radial, short cases, get them home.
Radial, I agree with that. And you saw that she dilated that very nicely. Now here, I think you do have to see what you're going to stent, no?
Okay, so what did
Yeah,
you
it's a
change?
pretty long need for a stent.
Yep.
Now, Dr. Kinney, Dr. Sharma's ready in another lab.
Yeah,
Can
so
we
I
go to
think what
him,
we
or
will
you
do
want us
is
to
we
stay
are
with
just
you?
going to do a 3538 Sierra stent here and take care of that entire lesion. I think going back to the comment with the IVUS, not using dye, use just IVUS and do the PCI. That's an excellent way to do it, but one thing you have to be careful that definitely that study did show the radiation exposure was higher. So we got to be careful about that with us doing these kind of complex cases. The radiation exposure both to the operator and as well as the patient should be taken into consideration.
Yeah, no, but I think, using imaging in a case like this, not giving dye is a very, very good thing. And then the Sierra stent, I think a lot of us now have it. We have it here at Mount Sinai, and I think it's been launched around. This is a much, much more deliverable, and I mean, and you all know how I feel about the Zion stent. I mean, I think this is probably we have the most amount of data. Are you happy to have that, Ron? Are you using it, the Sierra?
We are looking to have it next week launch.
Okay,
so
well,
Yeah, we're the
we
same.
heard a lot about it, but we
it just
we haven't-
really
Yeah, we're
truly
next
flies.
week.
Anybody has used it? Anybody here? Alex, the
Yeah.
Sierra?
Yes, as you said, nowadays I have to say that the latest generation, DS, it's very difficult to find any huge difference, but the Sierra is certainly for tortuous anatomy.
For tortuous anatomy. Charlie? I mean, sorry.
Good.
So,
Chambers, Jeff?
long stent, stent length, are you using the long stent so you make sure you don't miss because you don't want to use extra contrast? Is
Yeah.
that kind of why we're favoring the long
And
stent?
you see she's going for a pretty long stent,
Right,
going
right.
normal to
So-
normal. Dr. Usia, any
Yeah,
comments
I think
before
this
we
is
go?
even going to have to be overlapped. It's longer than 38.
Yeah.
You would make it longer than 38?
I think it is long. If you IVUS this, I guarantee you would put more than 38 millimeters in
Yeah, I mean,
there.
this artery is going to be, whenever you're going to look at this, it's not going to be perfect.
See, that's-
Dr.
that's
Usia,
518.
any comments?
Yeah, I would tend to go on the shorter side,
Oh.
actually.
No.
My only comment is
Sierra.
that I would not use the Impella in this patient.
Yeah, good. All right, so what did you do here? We got to go to Dr. Sharma's lab.
1 cc dye, and I think we may need a proximal stent also.
Yeah.
Why don't you IVUS it, or you don't have
You want to IVUS it?
Huh?
You're going to IVUS it and see if you need a stent, or you're just going to put a stent and come
I
out?
mean, the more stents you put, the more likely you'll have restenosis, because again, patients with CKD tends to have a little bit more restenosis than the regular patients, so we have to be wary about it.
Okay,
Right.
while you make that decision, if you don't mind, I'm going to go over to Dr. Sharma,
Okay.
and you'll tell us, just show us the final result after we come
Okay,
back.
we'll
to you.
IVUS it. No problem.
Yeah,
That's
thank
what
you.
the panel wants, we'll do it.
Thank you, thank you. That's nice.
Well, the IVUS got